Assalamu alaikum. Okay, let's discuss about hematuria in detail. Hematuria means presence of blood in urine. Okay, how can we evaluate gross hematuria? Evaluation of gross hematuria. If there is gross hematuria, what does gross hematuria means? Gross hematuria refers to visible presence of blood in the urine, turning it pink, red, or tea colored. It may be due to renal causes, it may be due to urologic causes, it may happen due to coagulopathy. Okay, how can we evaluate? If there is any gross hematuria, history of trauma or suspected stone, yes. If there is trauma or suspected stone, yes. Imaging is CT scan or ultrasonography should be done. If no, obtain urine analysis and urine culture. Obtain urine analysis and urine culture. If there is any evidence of infection, give antibiotics. If new proteinuria, RBC cast, evaluate for glomerular cause. If there is any other etiology suspected like cancer, do imaging CT scan. You can do cystoscopy and urine cytology. So imaging like CT scan, cystoscopy, and urine cytology. So in gross hematuria, in a short, like if there is trauma or suspected stone, yes, do CT scan or ultrasound. No, obtain urine analysis and urine culture. Obtain urine analysis and urine culture. If there is any evidence of infection, give antibiotics. If new proteinuria, RBC cast, evaluate for glomerular causes. If other etiology suspected like cancer, imaging, cystoscopy, and urine cytology. Okay, evaluation of red urine. If there is red, brown urine, heme positive dipstick. If red or brown urine and heme positive dipstick, do urine analysis. In urine analysis, if there is more than 3 or more than 3 RBC, it is hematuria. If 0 to 2 RBC, it may be hemoglobinuria or myoglobinuria. In myoglobinuria, we know that rhabdomyolysis increase creatinine kinase, and in hemoglobinuria, it may be intravascular hemolysis and decrease hemoglobin and heptoglobin. Decrease hemoglobin and heptoglobin. Okay, now look at this question. This 12-year-old boy, intermittent dark urine, exertional fatigue for 2 weeks. He underwent aortic valve replacement with a mechanical valve for bicuspid aortic regurgitation a year ago. And he takes daily warfarin. Temperature normal, okay. Cardiac examination, regular heart rate and rhythm with crisp mechanical heart valve clicks. Abdomen is soft, non-tender. There is no edema. Blood is 3 plus. Blood is 3 plus. Okay. mm, Specific gravity is 1. There is no RBC cast. There is no RBC cast. Which of the what is the best next step? With I think that best next step, as there is blood in the urine, if as urine analysis show 3 plus blood, so do a CBC. Do a CBC. Okay, we have already read this chart. Okay, there is another important thing that RBC is 1 to 2 high powerful. If RBC is more than 3, it should be hematuria. If RBC is 0 to 2, so it may be hemoglobinuria or it may be myoglobinuria. And it is hemoglobinuria because there is no increased CK, there is no history of rhabdomyolysis, so looks like cause in these two. Okay, so this patient with dark urine has heme positivity on urine dipstick, but very few urinary red blood cell finding that occur with myoglobinuria and hemoglobinuria in the absence of muscle X. In the absence of muscle X rhabdomyolysis, this patient mechanical aortic valve likely has hemoglobinuria, a condition in which free hemoglobin is present in the urine, increased turbulence through the prosthetic valve causing shearing forces of the RBC, which can lead to intravascular hemolysis, and release of free globin and release of free hemoglobin. Hemoglobinuria occurs when free hemoglobin exceeds both the saturation of the serum heptoglobin and the resorptive capacity of the proximal tubule. The result is urine. The result is urine in red, hemoglobin pigmentation brown, methemoglobin pigmentation. So red is hemoglobin pigmentation, brown is methemoglobin pigmentation with detection of heme positive blood in on urine dipstick, but with only 0 to 2 RBC in the urine, which is normal, considered negative in contrast to hematuria 3 or more than 3 RBC on the high powerful. So our next step in this pediatric infant is to do CBC, complete blood count, to confirm and assess the severity of anemia, which is likely cause of this patient's exertional fatigue. Additional findings of mechanical intravascular hemolysis include low heptoglobin, elevated LDH, increased reticulocyte schistocyte on peripheral blood smear. Okay, okay, now look at here. Hematuria throughout the urinary stream. If hematuria throughout the urinary stream is maybe renal mass, maybe benign or malignant, maybe glomerulonephritis, urolithiasis, PKD, pyelonephritis, urothelial cancer, and trauma. It is in the upper collecting system. So if the hematuria throughout the urinary stream, it should be upper collecting system. In lower collecting system, it should be terminal hematuria. Like urothelial cancer, cystitis, urolithiasis, BPH, and prostate cancer. It causes terminal hematuria, and initial hematuria is urethritis or trauma. Initial hematuria is urethritis or trauma. And okay, initial hematuria is characterized by blood at the beginning of the voiding cycle, often reflects the urethral source. So initial urethral beginning of the voiding cycle, at the beginning of the voiding cycle, total entire voiding cycle, total hematuria entire voiding cycle. So it can happen bleeding from anywhere like urinary tract, bladder, and kidneys. And is at the end terminal at the end of the voiding cycle, often suggests bleeding from prostate, bladder, neck, or trigone posterior urethra. So initial is urethral, terminal is Trigon, terminalis prostate, terminalis posterior urethra, and bladder neck. Significant exertion, long distance running can lead to dark urine due to the following: myoglobinuria from the skeletal muscle injury, rhabdomyolysis, March hemoglobinuria. It may be due to exertional hemoglobinuria, mechanical red blood cell damage, hemolysis in the vasculature of the plantar surface, and benign hematuria from bladder due to traumatic injury to the bladder mucosa. Okay, it is diagnosis, clinical treatment is self-limited. Benign hematuria, diagnosis of exclusion, repeat urine analysis after a week. Okay, if there is hematuria in children, like gross hematuria, sorry, hematuria more than 3 RBC, it may be glomerular, it may be non-glomerular. If it is glomerular, then creatinine complement level and CBC should be done. So in glomerular, CCC, CBC, creatinine and complement. And in non-glomerular, how will you understand that it is glomerular? In glomerular is brown urine, there is edema, most important there is a hypertension, not massive proteinuria, but there is RBC cast. So RBC cast, hypertension, proteinuria, edema, if these findings are found, then it is glomerular hematuria. And in non-glomerular hematuria, you should look, is it symptomatic or is it asymptomatic? If it is asymptomatic, consider renal ultrasound, urine culture, urine calcium to creatinine ratio. So if it is asymptomatic non-glomerular hematuria, then serum, renal ultrasound, urine culture, urine calcium creatinine ratio, and for symptomatic trauma, if there is trauma history, do CT scan of the abdomen. If UTI, do urine culture and antibiotic. If there is perineal or meatal irritation, irritation should be done. And if there is kidney stone flank pain crystal, then renal ultrasound should be done. Okay, now look at this final question. This 6-year old boy, okay, bright red urine for the past day. Okay, there is blood 3 plus. Where is the RBC? RBC is plenty, more than 3. RBC is more than 300 plus. WBC is 2 to 4, high power field. So more than 3 RBC. Now you should find, is it glomerular or is it non-glomerular? It is not glomerular. Why? There is no hypertension. There is not proteinuria. So protein normal, no hypertension, not glomerular. It is non-glomerular. This patient looks like he has no dysuria, no symptom. He is asymptomatic. There is just blood in the urine, and after urine analysis, we found this. What, it is asymptomatic. So our option is renal ultrasound, urine culture, and urine calcium creatinine. So it is renal and bladder ultrasonography. So gross hematuria with no history, signs and symptoms of infection, evidence of glomerular disease. A common association as in isolated gross hematuria in children include meatal irritation, which is painful and may be visible on external examination. And nephrolithiasis. Classic symptoms of nephrolithiasis is flank or abdominal pain, commonly occurs in older children, adults, as the stone as passes through the urinary tract and obstruct the ureter. However, in young children are most likely to have stones located in the kidney, which are painless. So in young children, if there is stone in the kidney, it is painless and can cause atypical presentation like gross hematuria as seen in this patient. Apart from confirming hematuria, urine dipstick positive for blood, red blood cell, and microscopy. And urine analysis may be otherwise unrevealing because characteristic crystals are not always present. A major risk factor for nephrolithiasis is hypercalciuria, which may be suspected because of the previous history of microscopic hematuria and confirmed with elevated spot urine calcium, and it is confirmed by elevated spot urine calcium creatinine ratio. The preferred imaging is renal and bladder ultrasonography, which can detect some stones and ureteral obstruction while avoiding radiation exposure. Okay, ultrasonography is the initial imaging study of the choice for excluding less common but serious other cause of non-glomerular hematuria such as renal mass, a condition in which associated with abdominal mass swelling. If ultrasonography is a non-diagnostic, CT scan of the abdomen without contrast may be required because it is more sensitive for identifying the small calculi. So that is all about hematuria in detail. Hope you enjoy.